Is it possible to sit?
If we can just state your name and who you represent, if we can just make your statement just very brief, and so we can move on. Thank you.
How many minutes do I have?
Just brief statement, please.
Brief, like 1 minute, 5 minutes?
I was supposed to have been gone half an hour ago, so
All righty. My name
I
is...
can do one of two things. If it's going to be long, I can turn over to Senator Bell, and I've got to leave.
Haven't put it in writing, too, I think.
1 minute.
1 minute.
1 minute, okay. My name is Barbara Wilson. I am a psychiatric social worker with Mental Health Hookup in Los Angeles County. I bring you information and suggestions about ways to handle homelessness with regard to chronic recidivists in the mental health system. And I also am bringing you some comments from parents and other relatives of people that have chronic forms of mental illness. So I brought copies, however you'd like to distribute them.
I'll take a minute.
Okay, so these are the comments from family members, and these are mine.
Thank you.
Oh, and here's one. I only have one copy.
Thank you, Mr. Chair, members. Christopher Castrillo from the California Academy of Child Adolescent Psychiatry. I just want to say thanks to you and the speakers for this hearing here today. Just briefly want to echo what our member from NAMI, Oshped, frankly, your questions. Nearly everybody who came up here today in the question of the parity equation is access, and we just want to voice our commitment to working with you and the stakeholders here today on trying to recruit, train, and retain not just child and adolescent psychiatrists. The two child adolescent psychiatrists that are here today probably represent too significant of a portion of those available in California right now, but for all mental health professionals, and we look forward to working with you on trying to solve that problem. Thank you.
Hi, I'm Leah Nagy from Humboldt County, home of redwood trees, the Emerald Triangle, Humboldt State University, and many individuals with mental illness and their families. I am a family member. I'm vice president of NAMI Humboldt. I am here to tell quickly the story of my grandson, 23 years old. Today's his birthday, and he is in Twin Towers in Los Angeles because of lack of insurance coverage. His parents live in Redding. They have Blue Cross Blue Shield. On 3 separate occasions, my son, who's a music teacher, and my daughter-in-law, who's a nurse, argued for the recommendation of the psychiatrist was to keep Keith longer in the mental hospital. The insurance company refused to cover that. They discharged him. He was still manic and psychotic. So he is now in jail, and I think it could have been prevented if they could have just kept him a little longer to get him stable. And so the other quick issue is his sister in Redding needed an out-of-network provider for attempted suicide, and the discharge plan called for one. The insurance company, again, Blue Cross Blue Shield, denied. When you're in a rural county, there's not a lot of providers that are in the network. So the insurance company refused to pay for it. My son and my daughter-in-law fought for 1.5 years, and like the psychiatrist mentioned, they were educated. They finally won and got the counseling covered. But these are just some of the parity issues that I wanted to bring to your attention. And my son, I was told 20 years ago, get him off private mental health insurance, put him on Medi-Cal, which I did, the best thing I could have ever done in my life, because back then they didn't have any coverage at all through Blue Cross Blue Shield, 30 days a year or something. He's doing well. He got the treatment he needed. He was kept as long as he needed to be, and he's in recovery. So thanks for listening. I appreciate that.
Yes, hello. My name is Rose King, a founder of a Right to Treatment campaign for parity in Medicaid managed care plans. Right now, California has no plan to extend parity to people on Medi-Cal. The agencies that determined my son was disabled by his serious mental illness, and his Medi-Cal treated him for physical illnesses that covered top quality treatment for hepatitis B and C, and his autopsy showed that he was completely free of the virus when he died because of his mental illness. There are no standards of care in Medi-Cal mental health systems. That's 700,000 people that are in county systems with no obligation to provide essential treatment. And those emergency rooms full of people are people on Medi-Cal. I mean, that was the LA Times report and quoted several emergency room doctors on that point. So I ask you to please consider to introduce a bill to extend parity to Medicaid managed care plans. The bill is already written, actually. Assemblywoman Helen Thompson, reformer Assemblywoman, was just here and had to leave, but she introduced that bill in 2001, and I drafted the bill as a consultant for the Assembly Health Committee at that time, which she chaired. So I hope the bill's written. I'll tell her how to find me. Thank you.
Thank you.
Greetings, members. My name is Sharon Jennings. I'm not really a data person. I know this hearing, a lot of it is about accountability and such. This is more personal for me, strictly from the heart. I didn't really want to be here today, as I have already spent 31 years working in this building for the Senate. I do feel, however, that I owe a debt of gratitude to my California legislature for having had that privilege. I did retire in December of 2013. I also owe a debt of gratitude to my brilliant team of psychiatric clinicians at Kaiser Permanente. I have been a consumer of mental health services for 40 years. It is because of their ongoing care and treatment that I am able to speak before the legislature today. Last year, members, my 55-year-old brother, severely depressed and untreated, took his life by jumping in front of a train. It strikes me now that in the year of 2015, we are so far behind in terms of mental health care being equal to physical health care. And stigma happens. I think that if we didn't have so much stigma, we might not have so many of these problems today. Stigma permeates our culture to the point that there are those who will not or cannot seek treatment. It really is very simple. Mental health and physical health go hand in hand to serve the whole individual. So, shall we not spend so much time with data analysis, review, deliberation, discussion, subject matter hearings, and so on? And we can't keep waiting for the 2-year legislative process. Action is the magic word. And I do know that magic happens in this building. I have seen it. We can do this, members, and turn things around for our great state. Please let me know how I can help. Thank you.
Yeah, good afternoon. I know it's been a long day. My name is Andres Scoya. I'm a psychologist. I've worked for 35 years at Kaiser Permanente as a chief of service in various regional and local roles. Most recently, I've been also part of the NUHW union, where we have been very much concerned about quality of patient care at Kaiser and have embarked on a 7 or 8 year long campaign really to be able to highlight what's really a moral issue and what's really a civil rights issue of diminishing the degree of discrimination against mentally ill people. And I also have a mentally ill person in my family. I have a son who's 22 years old who's been in and out of institutions. But I'm speaking as a psychologist who's been involved in this effort to be able to address substandard care and be able to bring forth ethical care. And as a Kaiser psychologist, I just want to say to the Reagan family, I am very, very sorry for what happened to your mom and for what your family went through. And I wish that the organization would be able to own up to that comparably. The experience, behind a lot of the optimistic and upbeat statements and data and so forth that you've been hearing, there's really a story, a behind-the-scenes story of what really happens in the clinics and what happens when you're sitting in a room with a patient across the room from you. And we just want to be able to make sure that the implementation and enforcement of various kinds of of policies, DMHC policies that keep organizations accountable is done effectively enough, because we know for a fact firsthand that it has not been. That we have, even now today, group therapies and chemical dependency programs that have 40 people in them. That's therapeutically impossible to deliver ethical and, I think, quality care. We have patients being referred out to the community out of frustration, who then have to pay for services or do without it, and face financial hardships because of help that they need that they weren't able to achieve within the organization. And over-medication, the reliance of that instead of individual psychotherapy and things that we've heard about throughout today. So, our attempt has been to provide professional level care, and we've tried to do that, and despite a lot of denials and obfuscation from the organization and fines and other things, I think it's been a process whereby the union has tried internally to work with Kaiser. When that wasn't successful, we went to DMHC and used other resources. And we're proud, actually, of some of the changes that Kaiser has brought about. And by all means, Kaiser does get many things right and is very effective. And this is not meant to disparage the entire organization at all. I'm proud of some of the things Kaiser does. But in mental health care, they have a long ways to go. And what we've heard today is just a start. I also want to express some disappointment at DMHC, who now has been sitting on this for 32 months since their first report came out in March of 2013, and 10 months since the February 2nd second report identifying problems. Meanwhile, while all those months go by, people in the community, our families, our friends, your neighbors, your communities are suffering. Those people continue to get insufficient care, and it's up to, I think, DMHC to, who has already identified areas of deficiency, to be able to enforce the law and be able to deliver on its mission to provide adequate care. So I just want to make those couple of points about DMHC stepping up to the job, to sort of speak, because this has been too long and too much. Too many patients are at risk while the wheels of the bureaucracy turn. And DMHC has powers it hasn't used under Knox-Keene and enforcement and inspection and audits and so on. And we wish that they would be a little more robust in their approach. Thank you very much for your attention.
Good evening. Thanks very much to the two committees for holding this hearing today. My name is Fred Seavey. I'm the research director at the National Union of Healthcare Workers, and we represent about 3,000 mental health clinicians who work inside of Kaiser clinics across the state. I wanted briefly to mention three concrete ideas, suggestions for the two committees. As Dr. Scoia mentioned, we've been involved very much in this enforcement effort over the last multiple years, submitted more than 1,000 pages of records to the DMHC, had several dozen whistleblowers step forward, some of whom suffered firings in retaliation for their testimony to the DMHC. So are very much familiar with the enforcement sort of activities of the Department of Managed Health Care. So with respect to the three concrete suggestions, one, several of you all mentioned the mismatch between the DMHC's findings over two successive investigations about failures by Kaiser, and that compared to this California Office of Public Advocate, or Patient Advocate. Why is it that Kaiser got 4 stars and the highest rating, whereas the department itself have found massive violations that have left thousands of patients without timely access? And the reason is that the Office of Patient Advocate looks at only 6 very sort of cherry-picked measures with respect to behavioral health services, and none of those address the question of timely access, for example, that Barbara Reagan suffered. For example, the only one that approaches timely access is whether a health plan, after a patient is discharged from an inpatient psychiatric hospital stay, has some sort of follow-up within 7 days after the discharge. But there's nothing that addresses the issues that the DMHC has uncovered and our sort of whistleblowers have identified, which is timely access to routine, non-urgent behavioral health visits. So one would be, can the legislature instruct the Office of Patient Advocate to alter its the measures that it investigates and tallies? So that's number one. Number two is simply to echo what Dr. Scoia mentioned. enhance the enforcement activities. In June of 2013, the DMHC issued a cease and desist order and said patients may have been at risk of harm. Thousands of patients, according to their records, were being denied timely access to care. They fined the company, ordered them to fix the problems, ordered an expedited follow-up survey. We're now approaching 2016, and in February of this year, the DMHC reported its own investigators found that 1 of every 5 patients in Northern California were not receiving timely access to care. How can this happen? Why hasn't the agency taken more aggressive actions? We think there needs to be a more robust enforcement action. And thirdly, and lastly, simply, what about this as a possible enforcement, a new sort of tool to add to the enforcement kit? Some people have talked today about, well, part of the problem that patients aren't getting timely access is that all of the new enrollees who are being brought into these health plans through Covered California. What about this? That if a health plan is not providing timely access to its existing members, perhaps the legislature should tell that health plan, no new Covered California enrollees in your plan until you fix the problem. Until you can provide timely access to your existing enrollees, until you can provide an adequate sort of provider network to treat your existing enrollees, you can't add more enrollees into the plan. And how about this as an option to, and this could serve as an incentive for health plans like Kaiser to address and fix these problems more rapidly. Thank you.
Good evening. My name is Vernon Brown. I'm the CEO for AspiraNet. I've had the pleasure of working with Senator Bell in his office on foster care issues. And I just wanted to raise the issue of parity and access for mental health services for youth and children in foster care in the child welfare system. I know it's a little bit off topic here today, but I think it's really important that access and parity as we go forward with AB 403 and the continuum of care reform is going to be hugely important. But I also felt compelled around talking about when Dr. Mordecai raised the issue of access to specialty mental health services and the stigmatization of that. I really want to counter that. The private sector, nonprofit mental health providers under Title 19 in partnership with public mental health systems across the state have been at the forefront of opening up and providing services. And I think that it's important that we don't get lost in the ACA and the HMOs coming to you, to the state, and asking for access to that Title 19 specialty mental health care before they're held accountable for the parity and the access and the issues that were discussed today. And so I think it's really an important issue. And I appreciate the opportunity to speak on that. I can also inform, Kaiser, that 17 of my clinicians from across the state of California, I made sure I checked on my phone with my mental health director, are now Kaiser employees. And so the private sector has really, nonprofit private sector has really stepped up, and we've lost many fine clinicians over the last couple of years as the HMOs have increasingly had to meet the parity. And that's a good thing, but at the same time, we need to recognize the private sector in that regard. Thank you.
Hi, I'm Shing Long, and I am the director of a nonprofit here called the Soldiers Project. We provide free, ongoing, confidential psychotherapy services to all post-9/11 veterans. I don't know if you know this, but 22 veterans take their own life every single day, more than out in the combat zone. We believe in making sure that these veterans have access to these services, and we do this regardless of their discharge status. So I appreciate you being here today and being able to have the opportunity to learn a little bit more about how these developments will impact the access for veterans as well who are suffering. So thank you.
My name is Dolores Sanchez, and I am here representing, I'm a founder of Mental Health Justice, and Mental Health Justice is a peer-to-peer community on the internet, both on Facebook and with a daily blog on mentalhealthjustice.net. My history is that I worked in this community and the legislature for many years, and then was an advocate for the California Federation of Teachers for 23 years before I was met with a crisis in my life, a mental health crisis, and as such, I lost my job, and so I come to you from the perspective of a consumer in that, I had a union contract, so I had pretty good healthcare services and healthcare services in general and mental health coverage specific. And of course, that went away once I I no longer had my job, so I had to go on COBRA. And but I back up for just a second in terms of a couple points that were brought up here today. One is the person from the Department of Managed Healthcare talked about this help center and to access that help center. I've never heard of that help center, and I don't know anybody who has heard of it. So if it's there, I'm wonderful, and I look forward to looking at those services. But I cannot believe that they are widely publicized because I looked high and low and could not find any type of services like that. I was diagnosed in 2013 with severe depression, and so I advocated for 23 years on behalf of school employees here in the Capitol, but when my crisis, when my depression took over, I could not advocate for myself. So it's very hard. It's sort of like trying to manage the management of this illness is extremely difficult, but it's almost impossible when you can't get out of bed. So I think that's one thing that I wanted to leave with you. The other thing is that to try to find a healthcare provider, just like everyone has talked about, is extremely difficult. And again, I had access to some really good care, and even that took a great deal of time and patience. I had a certain level of care, then I was denied that care. I tried to appeal it. I called to appeal, to find out how to appeal, which is extremely overwhelming when, again, you are operating and functioning at a very low level. And I called to appeal, and 3 weeks later, I hadn't heard from them. I finally got a correspondence that said my appeal had been denied. So I'm not even sure I don't even remember that I appealed, but after that, I gave up. So I just want to tell you that this is very real, and there's a great deal of stigma out there, and that's why I created mentalhealthjustice.net. And I think that, bottom line is we all have to work together because people are not being served. Because if someone like me who, has had a certain means and education level and access to people like all of you, and your staffs, if I could not get help, then I can't imagine somebody who comes who doesn't have as much means and doesn't, has language issues and et cetera. So thank you very much for holding this hearing, and I look forward to working with you.
Seeing no one else for public comment, we will adjourn this meeting. Thank you.
Thank you, Ed.